Camilo.
Yes, thank you, Julie, for the introduction. My name is Camilo Vasquez. I'm a PhD candidate from the Friedrich Alexander Universität Erlangen-Nuremberg in Germany. And today I'm going to talk about the main results of my PhD about modeling the progression of neurological diseases, particularly about the multimodal assessment of Parkinson's disease patients, combining information from speech, handwriting, and gait. So, Parkinson's disease is the second most common neurodegenerative disorder in the world after Alzheimer's. Patients develop several motor and non-motor impairments, which include tremor, slow movement, rigidity, bradykinesia, lack of coordination, among others. In general, approximately between 70 and 90% of the patients develop a multidimensional speech impairment, which is called hypokinetic dysarthria. Now, despite Parkinson's disease is not an infectious disorder, the disease exhibits many of the characteristics of a pandemic similar to COVID. For instance, pandemics extend over large geographic areas, and Parkinson's disease is increasing in every major region of the world. Pandemics also tend to migrate, and Parkinson's disease is shifting in response to changes in aging and industrialization of the people. Finally, similar to other pandemics, Parkinson's disease is experienced also an exponential growth. It is the fastest growing neurological disease, and no one is immune to the condition. But the diagnostic criteria for the disease is based on the presence of motor symptoms that appear when the dopaminergic neurons in the midbrain have been reduced in about 80%. In addition, it can take more than 20 years for the motor impairments to appear. This is especially difficult for most of the patients because, in general, the rate of misdiagnosis is also high, especially when it's performed by a non-specialist neurologist. So in general, and for all of these reasons, it is important to identify accurate biomarkers for early diagnosis, a severity estimation, and evaluation of the response to therapy. And all of them are primary goals of the research on Parkinson's disease today. So it's important to develop a continuous monitoring of the state of the patients in order to help to slow down the impact of the disease and to improve the quality of life of patients. In general, we believe that monitoring of motor symptoms of Parkinson's disease patients will gradually shift from the clinic to at home, where a continuous and non-intrusive monitoring can be performed, combining information from speech, gait, smartphones, and wearables. Yeah, the ultimate goal is to help in the early diagnosis of the disease, in the evaluation of the severity of the patients, in order to prescribe them with better treatments. Now, the outline for the rest of this talk is as follows. First, I will talk about the main methods considered for the assessment of speech, handwriting, and gait of patients with Parkinson's disease, followed by the data that we collected for this study, the results, and conclusions on future trends. Regarding speech assessment of Parkinson's disease patients, as I already mentioned, almost 90% of the patients develop this multidimensional speech impairment, which is called hypokinetic dysarthria. The main symptoms include increased acoustic noise, harsh and pretty voice, monopitch, monoloudness, among others, and it generally appears in initial stages of the disease. Usually in the literature, the Parkinsonian speech has been addressed using three main dimensions of the speech, which are phonation, articulation, and prosody. In terms of phonation, features and model are designed to evaluate abnormal patterns in the vocal fold vibration. And the traditional features include perturbation features from the loudness and speech, like jitter and shimmer, and also metrics and measures computed from the glottal source reconstructed signal. Regarding articulation, these are designed to model the difficulties of the patient to start or to stop the movement of the vocal folds. Particularly, we focus on the analysis of the energy content in the transitions between the unvoiced segments and voiced segments. Regarding prosody, these features or these models are designed to model the monotonicity and monoloudness which are exhibited by the patient, and we focus particularly on evaluating statistics of pitch, contour, loudness, duration, and speech rate. However, these classical and traditional features extracted in the literature probably they not completely capture enough information to characterize the speech signals associated with Parkinson's disease. This is because the research community has focused in the last years to evaluate 4 different methods or 4 different methodologies to accurately evaluate with the speech of Parkinson's disease patients. Particularly, we focus on speaker models, which are like adaptations of methods for speaker recognition, like Gaussian mixture models, universal background models, like vectors and X vectors, and adapt them in order to evaluate Parkinson's disease speech, what is the severity of dysarthria, and to classify as well between Parkinson's disease and healthy control subjects. We have phonemic features, which are represented with an interpretative information about the placement and manner of articulation. These phonological features are the posterior probability of a speech frame to belong to one or more phonological classes like stops, nasals, vocalic, labials. Particularly, we can train a deep neural network approach for phoneme recognition or for phonological classification. And then we use these phonological posteriors to characterize and to evaluate the presence and the severity of Parkinson's disease in speech. In the third group, we have representation learning strategies. In this case, we have embeddings derived from a neural network, which is trained using healthy speech signals to represent pathological speech signals. Particularly, we focus here on a recurrent autoencoder and extract, which is trained using healthy speech, a big corpus of healthy speech, and focus on extracting information in the bottleneck features, the bottleneck layer here between the encoder and the decoder, and also to measure the mean square reconstruction error in different frequency bands. Finally, the end-to-end models. The aim here is to feed directly convolutional and recurrent neural networks to make the final decision about the presence and the disease severity of the patients. Particularly here, we focus on an adapted version of our ResNet 18 architecture, which is trained with spectrograms of the spectrograms computed from the voice to unvoiced transitions, the onset transitions from voice to voice segments in order to evaluate as well these articulatory capabilities of the patient to start or to stop the movement of the vocal folds vibrations. Now, this is about some models about the speech. Now, let's talk about some additional models to evaluate the handwriting in Parkinson's disease patients. The main symptoms to address handwriting in Parkinson's disease patients include bradykinesia, micrographia, and tremor. The traditional analysis about handwriting is focused mainly on kinematic analysis of the strokes in vertical, horizontal, radial, and angular position within a tablet to measure the velocity and acceleration of the strokes in different axes and the pressure and the analysis of the pressure of the pen. In addition to kinematics, we consider as well some and propose as well some inner modeling, which is the movements performed by the hand while a patient transitioning from one stroke to the next one within the air. We measure aspects like the number of pen downs, or pen ups and pen down transitions per second in order to evaluate the hesitations of the patient to start or to stop writing, and also the slope of the pen down and pen up transitions in order to evaluate like the stability of the handwriting process. We consider as well an end-to-end analysis of handwriting by using a stack of 3 one-dimensional convolutional layers to process the stroke signals collected from a tablet. This model is also trying to classify between Parkinson's disease and healthy control subjects and to evaluate the neurological state of the patients. Now, regarding the evaluation of gait in Parkinson's disease patients, and in general, Parkinson's patients consider mobility and walking limitations the most disabling aspects of the disease, and consistently they identify improvements in walking as the most relevant outcome when rating the success of a treatment, particularly using inertial sensors attached to the lateral heel of the shoe of the patients. We can track as well the severity and the presence of the disease. The main important symptoms in gait in Parkinson's patients include speed reduction, freezing of gait, higher risk of falls, and tremor, among others. Particularly, the traditional gait analysis in the patients include kinematic features to model and to evaluate the velocity, the duration, and the length of individual steps, the heel-toe angle when the patients are within each stride, among others. The spectral features, which are based on modeling the energy content in different frequency regions. Particularly, we focus on the motor band, which is the frequency spectrum within the normal gait signals appear between 3 and 5 hertz. And also the freezing band, which is related to the presence of freezing of gait episodes in the patients, and which includes high energy signals in the band between 7 and 9 hertz. And finally, kinematic and spectral features, as I already mentioned, are classical, and they are not sufficient to characterize some properties about the local dynamics of the walking process. Thus, in order to characterize such underlying complexity, recurrence, and stability during movement, there are some recent techniques derived from the chaos theory and nonlinear dynamics to model this stability, recurrence, and complexity patterns that appear in gait signals. Yeah, so we can define like additional representation space, which is called a tractor, to define this well-defined, to find this well-defined and complex structures that appear in the gait signals of Parkinson's disease patients. And we finally compare this traditional gait analysis with an end-to-end modeling approach using 1D convolutional layers to learn a filter bank from the raw gait signals, combined with bidirectional gated recurrent layers to model the temporal structure of the sequence, and an attention mechanism to learn and give more importance to specific parts of the gait sequence, like poses, the swing phase, the stance phase, among others. Now, all of these experiments and all of these models are tested with a data set collected by us for this PhD. It includes speech, handwriting, and gait signals collected from 100 patients and 100 controls, more or less. All of them are Colombian Spanish native speaker, age and gender balance. The neurological state of the patient was labeled according to the Movement Disorder Society Unified Parkinson's Disease Rating Scale, and the SUPDRS, which is a neurological scale to evaluate the patient and ranks from 0 to 128. So this 36 indicates that almost all of the subjects are in an intermediate state of the disease. We also have labels about the dysarthria level of the speakers, evaluated according to a modified version of the French dysarthria assessment scale. This modification that we perform is to guarantees that the evaluation can be done remotely, like just listening by an expert phoniatrician to listening the recordings of the patients. Yeah, the MFDA scale ranks from 0 to 52, and in higher indicates higher dysarthria levels. And in this case, almost all of the patients are also in an intermediate dysarthria severity scale. Collected speech using a headset, handwriting signals using a tablet, and gait signals using inertial sensors, accelerometers, and gyroscopes attached to the shoes of the patients. Now, some of the results, particularly we focus on the classification between Parkinson's disease and healthy controls, the evaluation of the dysarthria severity of the patients using speech, and the evaluation of the neurological state of the patients, combining speech, handwriting, and gait. Now we can start like evaluating the classification of Parkinson's disease and healthy controls using speech and using all of the presented methods like phonation, articulation, prosody, the phonemic feature, the representation learning using autoencoders, and the end-to-end modeling approach using the combination of convolutional and recurrent neural networks. We have the results in terms of the weighted average recall, word, sensitivity, and specificity. We observe here that the best result is observed with the end-to-end modeling approach, with a 96% accuracy to differentiate between Parkinson's and controls, followed by the phonemic feature extracting using the phonological posteriors. Yeah, we observe here that traditional and more standard features like phonation, articulation, and prosody, since they only model certain aspects of the disaster severity, they are not able to model the full spectrum of the disaster severity of the patients. Now, regarding the assessment of the disaster severity, we just use these traditional features and models to train a regressor approach based on support vector regression for the case of the representation learning, phonemic, prosody, articulation, and phonation. I use the end-to-end modeling approach as well. In this case, we observe that the best results are observed. The most correlated method is the phonemic features. We are able to evaluate and to predict the disaster severity of the patients based on with a correlation of 0.61 using these phonemic features, phonological posterior based features. We also aim to evaluate the neurological state of the patient based on the MDS UPDRS3 score and using the same methods regarding using only speech. In this case, none of the model is enoughly accurate to evaluate the neurological state of the patients. This is kind of expected since this UPDRS scale is a complete motor scale in which only one of the items is related to speech symptoms. Thus, it is better to consider a specific scale to evaluate only the speech symptoms of the patient, like the MFDA or the FDA. Now, regarding the classification of Parkinson's disease versus healthy controls using handwriting and using the kinematic features, inner features, and the end-to-end modeling approach. In this case, we are able to discriminate between Parkinson's and controls in handwriting with an accuracy of 99% using the end-to-end modeling approach, using the convolutional neural network, followed by the inner features, which is also very accurate to detect or to differentiate between the two populations, 96.2 accuracy, with a balanced sensitivity and specificity. However, when we aim to evaluate and to predict the neurological state of the patients using the handwriting signals, in this case, the best result is observed with the kinematic features. Particularly because, kinematic features are more generally considered and includes a lot of information to model the full spectrum of handwriting symptoms or symptoms in the upper limbs of the patients, which are more accurately evaluated to evaluate the neurological state of the patient or the global neurological state of the patients. In this particular case, the end-to-end modeling approach is not very accurate to evaluate the neurological state of the patient. This can be particularly explained because we don't have enough label data to train a robust regression approach using convolutional neural network in this case. Finally, regarding gait analysis, using the kinematic, spectral, nonlinear, and the end-to-end modeling approach, we are able to classify Parkinson's disease patient and healthy control with an accuracy of up to 98% using the end-to-end models and up to 94% using the nonlinear features. And when we aim to predict and to evaluate the neurological state of the patients, the best results here are observed as well with the nonlinear dynamic based features, which maps completely the full neurological state or the full set of symptoms in the lower limbs of the patients in order to predict the neurological state of the speakers, of the subjects. If we combine the outcomes of the speech signals, the best results using speech, the best results using handwriting, and the best results using gait, using a late fusion strategy based on AdaBoost, we are able to slightly improve the classification accuracy up to 97%. These results slightly outperform those obtained with each modality to differentiate between Parkinson's disease and healthy controls. And if we do the same in order to predict the neurological state of the patients, we as well slightly improve the results. However, in this case, the results are very close to those ones obtained using only gait signals. Now, in order to do some conclusion on future trends about this work, we present in general an automatic assessment of Parkinson's disease patients combining information from speech, handwriting, and gait, particularly for the discrimination between patients and healthy controls, and to evaluate automatically the disease severity of the patients. The speech analysis evaluates at the same time phonation aspects, articulation, prosody, and phonemic dimension of the speech. We include as well the evaluation of the representation learning strategies using autoencoders and end-to-end modeling approaches to characterize and to evaluate the speech of the participants. The handwriting analysis, we include as well traditional kinematic features and some proposed modeling based on the inner movements, and also end-to-end modeling strategies in deep learning techniques. Gait analysis, we include traditional kinematic, spectral, and nonlinear models, and also end-to-end modeling strategies. We observe and we report very accurate results classifying Parkinson's disease and healthy control subjects with the three modalities, the speech, handwriting, and gait, and their combination. And we obtain really promising results regarding the evaluation of the disease severity of the patients, both evaluating the disaster severity using according to the MFDA scale and the general motor state severity according to the MDS-UPDRS-3 scale. Some outlook and future trends to do research in this topic, and all of these models can be adapted to evaluate other patients with other different neurodegenerative disorders like aphasia, Huntington, Alzheimer's disease, among others. It's important as well to evaluate these methods in the detection of prodromal stages of the disease before the first symptoms to appear in order to perform early diagnosis, and also the assessment of different genetic mutations of the disease that cause or that are related to the disease apparition. It's important as well to perform a longitudinal assessment of the patient in order to track the evolution patient by patient through time, in order to prescribe them with better treatments and to evaluate the medication effect. All of these models can be combined with the analysis of additional modalities like text transcription and facial images, as well as performing synchronous multimodal analysis, for instance, the joint analysis of speech and facial images or speech and text at the same time. It is also important to evaluate which speech dimensions are more affected for each patient. For instance, some patients can be more affected within the plosive sounds, others are more affected in nasal sounds, in vowels. It's important to evaluate which speech dimensions are the most affected one in order to perform better therapy sessions. Also, it's important to evaluate non-motor symptoms of the patient like depression and cognitive decline, among others. So this is everything from my side. Thank you very much for your attention.
Thank you very much. Are there any questions?
Hi, I have a question, if I may.
Yeah, sure.
Okay. First of all, thank you very much, Camilo, for your talk. I just was wondering, do you have any idea why do you have good classification results with the end-to-end, but pretty bad with the regression task?
Yeah, I would say it is because it's very difficult to train a regression approach with these small amounts of data. We don't have, since I previously mentioned, almost all of the subjects are focused in one specific group of the disease severity. Almost all of them are in an intermediate stage of the disease. So yeah, the end-to-end models basically only learns to predict those that are in the middle, and the full spectrum of patients in initial stage, intermediate stage, and severe stage. Yeah, the model is not able to track them.
Mael, do you have a
Yeah.
question?
Hello, thanks for the talk. I had a question then. So basically, what you did for those patients is a couple of tests, and can you give us insights on how those tests could be, for example, integrated for early diagnosis? How long do those tests of handwriting and speech last, and how that could be integrated to detect the disease?
Yeah, I mean the test. I mean basically, patients have to do some very general speech exercises like the utterance of sustained vowels, some diadochokinetic exercises like the rapid repetition of pataka, 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 read sentences, read text. Regarding handwriting, there is a set as well of exercises to evaluate some handwriting capacities, drawing already drawing exercises, the same for gait. We have a protocol of walking like 10, 20 meters, or stand up from a chair, walking 10 meters and go back. Yeah, and for early detection, yeah, I think in general, the full set of exercises is about 1 hour duration. And for early detection, I mean, I think the most important aspect here is to find the population, or it's important to do these methods to find the symptoms or to track the symptom before the symptoms by itself to appear. So I think the most important aspects here is to have a population of pre-diagnosed Parkinson's disease patient in order to test whether these methods are accurate enough to evaluate these patient before the symptoms to appear. I mean, there are some works about the topic. For instance, patients with REM sleep disorders are very probable they will develop Parkinson's disease within the next 5 or 10 years, or also there are some patients with some genetic mutations that are related to the presence of Parkinson's disease in the future. So it's important to evaluate those patients in order to, with these methods, in order to track, for instance, if they have something special, either in speech, handwriting, or gait, before the symptoms to appear in the patient.
Okay, thank you.
We have time for one more question. Sorry.
I have one, Camilo. Thanks for the nice talk. I was wondering, when you did all this analysis about classification and so on, I was curious that, did you look at how this classification across different things like speech, gait, and handwriting? You're looking at 3 different things. Did you see any kind of systematic relation between these classifications and so on? Or they were, when you have 98% and all, it's very rare to see any big complementarity between the streams. But in the other system, did you try to see some kind of a relation there? I'm curious about that, because you did out just a fusion, right? At the end, you did a fusion experiment. But I'm curious, did you analyze the output by any chance to see if they bring any different information or something?
Yeah, since Parkinson's disease affects differently every patient. Not all of the patients have shared the same symptoms. For instance, there are patients with more problems in the upper limbs, so they are more accurate to classify via handwriting, and there are another ones for instance, whose speech is like a healthy speech, but their gait is very disabled or very impaired. So they are usually misclassified using speech, but they are very accurately classified using gait. Okay. And all of these.
Okay, that's interesting. So, but then when your performance is with end-to-end classification is around 97, 98, do you still see these differences, such differences?
I mean, if we check the signals or hear the audios, you
Mhm.
can perceptually check some, okay, this patient, but this guy speaks like a normal person, but when you check, for instance, their drawings, they are very impaired. Yeah, that's why I think the fusion will help as well to improve somehow the accuracy, unable to catch some these misclassified subjects in one single modality.
Okay. Thank you, Camilo. Thanks again.
Thank you very much. So, Abdessalem, if you can share your screen and you can go on with your presentation. Thank you.
Yep. Do you see my screen now?
No.
Oh, sorry. Yeah, it's just yeah, sorry. Just 1 second. I'll just okay. Share. And then this one. Okay. Do you see anything now?
Yes, it's okay.
Okay. Do I start?
Yes, you can start. Thank you.
Thank you. Hello, everyone. My name is Abdessalem hammami. Abdessalem is my first name. I am a PhD student at Ghent University, Belgium, EMEC as well. I started my PhD and this project around the end of 2020. My research project title is Generating Phonological Feedback for Evidence-Based Speech Therapy. And I'm supervised by Professor Chris de Monk from Ghent University, EMEC, and Dr. Carolina Spexnader from UMC Utrecht. So during this presentation, I'm going to start by a background section where I talk about the research context and motivation. Then I'll shortly talk about the research objectives we hope to achieve. Next, in the methodology section, I discuss the approach we are using to tackle the problems we're working to solve. And since the experiments are still ongoing, and as you can just guess, there's a gap of 2 years in the project, so results are not yet final. I'm going to skip that part for now, and instead I'll just close my talk with a few words on our next work and the next steps we are going to do on the project. So regarding the pathological speech, so as has been described and presented in previous presentations, so speech disorders, pathological speech is speech disorder resulting from malfunctioning part in the articulatory systems, example dysarthria, laryngectomy, cleft lip and cleft palate, stuttering, apraxia, and other disorders related to even to autism and several other problems, or even surgery and stuff. The problems that we are facing when dealing with pathological speech is that it is this each speech pathology is distinct from one another, and there's a variance, a great variance from the features of one disorder of speech to another disorder of speech. That is, we cannot generalize, or we cannot put all disorders in one bag. And the second problem we are trying to tackle is that the scarcity of the clinical annotated data. That is, in order to get professionally annotated data, it is very hard to get hand on such data, and that's why we have to deal with very small size of data. the problem we're trying to tackle is to get a system of pathological speech intelligibility. People need the possibility to interact with other people for almost all their basic needs. And in this regard, people with speech disorders really suffer from great functional and social discomfort as they deprive it from like a primary communication forms. In real words, the patient's intelligibility is measured using perceptual tests where speech therapists listen to a patient's speech and then rate it. This method is by definition subjective in nature, and it affects the reliability of the outcome. This situation begs the need for a more objective way to assess the intelligibility. Um, so because there are various tests and scales using various measurements, and each various intelligibility measurement has its own intelligibility interpretation, and that's why we need a more objective way to get around this issue. This brings us to talk about a tool that we have at UGent that is built and put online. It's called Assisto. It's an e-health tool. The tool gives feedback to the patients. That is, it evaluates the exercises of the speaking skills, and it gives feedback to the speech therapists. That is, it gives assistant, it gives the root cause of the analysis of the problems, and it measures the effectiveness of the exercise given to the patient. Um, the the tool is available online, and if you anybody could go to the web address mentioned in the slide, you can even try it. There is a trial option over there where you can use the service for a limited trial period. The objectives of this research is first to investigate deep learning techniques to develop a robust model that can generalize across various pathologies with so little data. The second objective is to investigate the effect of multilingual approach and test if this approach could improve the system's performance, and then incorporate cross-pathology and cross-exercise and multilingual training for more robustness of the system. In order to go about this approach, we use a data set. The data set is called Dutch Corpus for Pathological Speech. It's Corpus, and I believe some of the colleagues have used the same. The data set includes speakers that belong to 8 distinct pathological categories, as you can see in the table. And these recordings of the standard Dutch text passage, Papa and Marloes. There are total 305 speakers. I'm using, for the sake of training the system, 231 speakers as training set and the others for validation. We start, first of all, by doing the pre-processing of the methodology includes 3 phases: a pre-processing phase, a speaker feature extraction phase, and at last an intelligibility prediction phase. The first phase includes, it produces the spectral temporal representation of acoustic signal, and the second phase analyzes the representation and retrieves global features from the signal, and then it constructs a compact characterization of the speech of the test speaker. And at the last phase, we compute an intelligibility score based on the speaker features we got from the earlier phase. During the first phase, we do a pre-processing, a standard pre-processing with normal, that includes the normal phases, starting from the signal and doing all the steps until we get the features, the MFCC features. And then we tried MFCCs and we tried MEL spectrograms as well. And the models we have is First of all, we use the phone classification, and we get a 30 mel spectrograms. We put it into a model. We use a TDNN time-delayed neural network with 4 layers, and we have an output as a sigmoid probability for the phone to get, because this is a intelligibility based on the phone unit. So we have to get this, train the system for phone classification. And the second phase is do phonological feature extraction. We input the same 30 mel spectrograms, and we use the same model, which is a 4-layer TDNN. And the output is a binary output for the present phonological features. The current model performance is 95% accuracy on the training set. The actual plot of the phonological features is as you can see. This plot describes the correctly classified phonological features, and of course the ones in red are the mistakes. After that, we do an alignment. So the pathological speech is aligned with the text with a automatic speech recognition system, employing pathological models for normal Flemish speech. And then from this alignment, we derive the phonological speaker feature to describe how well the observed pronunciation of the phonemes in utterances are recognized by the automatic speech recognition system. And during the last phase of of our approach, we do the intelligibility scoring. So we have our data is comprised of 231 data points, data examples. Each data example is comprised of an input feature of 54 features, which are posterior probabilities. And our method is to use a 2 hidden layer DNN. And then we have at the end an output layer where it gives the score. The current result for now is 6.3 root mean square error. Actually, this method improves on the previous one used by the previous system. So we have around 10% improvement on the error rate. But of course, this is not, as discussed before, this is not final yet. We also are in the process of validating the system on different other types of data sets, not necessarily speech data sets, but other data sets that we could use for the regression problem as well. Now, because, as I mentioned before, because these experiments are still ongoing, so we do not have final results yet. But then what we intend to do after this phase is to keep working on the model, and because we have a collaboration with the UMC Utrecht to get a data set from them, on which we can use for to train our model and to check if it improves the accuracy. Another point that we are thinking to work on is that we start from the assumption that we can consider a pathological speech as a different language. Then we can train the model on multiple languages, like for any other languages, especially German, French, European languages, and then see how those multilingual training could improve the system on pathological speech. This brings me to the conclusion of this presentation. And if you have any questions, I'll be glad to answer.
Can you hear me? Yeah.
I can hear you.
Okay. So, are there any questions for Abdessalem? In the last slide, you mentioned that you can try on other languages.
Yes.
How long do you think it will be will it be like a retraining for the phonological analysis, or will it be like a transfer learning or something like that?
Yes, exactly. That's the point. So the point is using transfer learning. So what we do is that we are training the system on other languages, and then use the performance, the system performance and features from other languages to try to see how those how the training on other languages could benefit our model on pathological speech as well. And before that as well, we are, as I mentioned, we have a collaboration with UMC Utrecht, Netherlands, and they are providing us with a database of speakers who have undergone cancer surgery in their articulatory system. And we are going to use that database as well as another source of data to train the system and check if it improves the performance and if our system can generalize on many sorts of disorders as well.
And if I'm not mistaken, Juan Camilo, for example, is using quite the same architecture for Colombian Spanish for the phonological analysis. Yes, and Juan Camilo, you have also everything labeled for Colombian Spanish.
Yeah.
I think for Parkinson, so it's yeah, it
That'd
can
be
be
great. I mean, that's if that's of course I cannot know the possibility of collaboration or using that sort of data, but again, that's that would be very nice to just maybe talk later on about the possibility.
Are there other questions for him? So thank you very much, Juan Camilo and Abdessalem. It was very interesting talks. So as usual, I will put the talks on YouTube, and next week we will have the talks from Benz and from Thomas. So yes, see you next week, and thank you for for the interesting talks. Bye bye.
Bye.
Bye everyone.
Bye.
Bye.
Abdessalem. Bye.